Jane visited the breast clinic to address a concerning lump in her right breast, and much to her surprise, she was found to be 12 weeks pregnant. Now, you may have realized that the pregnancy complicates many components of her care. The big question being, can we treat cancer during pregnancy? Well, the answer is yes, but as you will see, the treatment and care become much more complicated. Now, what makes this population so complex is that both the obstetrical and the oncology teams will need to collaborate to make decisions about Jane's care, while minimizing the risks to her growing baby. A cancer diagnosis in pregnancy is rare. It actually only affects about 1 in every 1,000 pregnancies, but this number will likely increase. This is because more people are choosing to delay having children, and the risk of developing most cancers increases as we age. With this increased risk, it is becoming more apparent to understand how to best approach this population. Now, given the complexity and cancer in pregnancy, it is advantageous to integrate evidence-based practice in the care provided to these individuals. Evidence-based practice involves the integration of 3 intersecting components: the integration of the best available evidence, clinical expertise, and patient values. A key component of evidence-based practice is collecting the best available evidence on the uses, successes, and failures of medical interventions. In the absence of adequate external evidence, clinical practice becomes rapidly out of date, all at the cost of the patient's well-being. Using the best available evidence, let's review how we might approach our patient, Jane, who is suspected to have breast cancer during pregnancy. Now, the main concern with using imaging technologies to diagnose Jane's breast lump is that several of these procedures, including computerized tomography or CT scans, emit ionizing radiation that can actually harm the baby depending on the amount of radiation used. On the other hand, ultrasound uses high-frequency sound waves to generate images of structures of the body and provides no ionizing radiation to the fetus. Given its unique advantages, ultrasound should be the first consideration when there's a suspicious breast lump in a pregnant patient. Now, suppose that we performed an ultrasound of Jane's breast lump and determined that it's malignant. The next step would be to determine the extent of her disease. Now, say Jane is experiencing pain in her midsection, has a loss of appetite, and is feeling weak. Given her symptoms, Jane's breast cancer may have spread to her liver. Due to the proximity of the liver to the fetus, imaging the liver using methods such as CT scans can actually provide a high radiation dose to the fetus. A safe alternative, again, would be to perform an ultrasound of the liver, which can effectively help identify and evaluate metastases to the liver. Now, suppose that diagnostic imaging and pathology reports found that Jane has metastatic breast cancer that is responsive to a specific type of chemotherapy. Now what? Sure, we determined the extent of Jane's disease, but can we even treat it? Isn't chemotherapy toxic to the fetus? Well, during the first trimester of pregnancy is when the organs of the baby are developing. When chemotherapy is used in the first trimester, it results in birth defects in 14% of neonates, compared to just 3% in the general population. Now, in contrast, many types of chemotherapy drugs are safe to use during the second and third trimesters. This is because the risk of birth defects in these babies exposed to chemo during the second and third trimesters is the same as the general population. So, certain chemo regimens can be offered to Jane starting in the second trimester. Luckily, Jane's disease is responsive to a chemotherapy regimen that does not increase the risks of birth defects when used in the second trimester onwards, and she would like to go forward with this treatment. Now, what's important to note is that exposure to chemotherapy during pregnancy, even after the first trimester, can elevate risks of fetal complications, including the risks of premature delivery. So Jane and her baby will need careful fetal and maternal monitoring throughout her chemotherapy treatment. When taking precautionary measures, surgery may actually be the safest cancer treatment option for some cancers. But adequate anesthesia will be important because pain can increase the risk of a premature onset of labor. Because of this risk, the timing of surgery is often coupled with preoperative chemo to delay the surgery as late as possible within the pregnancy. So, Jane's chemo treatment can be timed such that she receives her first dose of preoperative chemotherapy after the first trimester and receive her breast surgery closer to her estimated delivery date. Now here, By using the best available evidence, we can determine that while there are certain limitations placed on the treatments we can use during cancer and pregnancy, treating cancer during this time is very possible and should not be disregarded as an option. Now, while external evidence can inform us about which treatments we can offer to Jane, evidence alone can never replace clinical expertise. It is the clinician's expertise that decides whether the external evidence applies to the individual patient at all, and if so, how it should be integrated into a clinical decision. The importance of tailoring the treatment to each patient becomes even more apparent in the context of cancer and pregnancy, where the inclusion of experts from multiple disciplines is necessary for treating a patient. For example, the oncology and obstetrical teams must coordinate Jane's time of delivery with respect to her last cycle of chemo. This coordination is necessary because chemo can actually lower blood cell counts, which can cause bleeding and increase the risk of infection during childbirth. Stopping chemotherapy at least 2 weeks ahead of the planned delivery date can allow for time for Jane's blood cell counts to return to normal before she gives birth. Now, the patient's values and preferences must always be put at the forefront when making decisions involving their care. External evidence provides us with the data to communicate the potential risks and benefits of treatment to Jane so that she can make an informed decision about her care. But external evidence should never take priority over Jane's preferences. Whether Jane chooses to terminate or continue her pregnancy, either with or without treatment, is ultimately her decision, and her decision should be respected. By using the evidence-based model, we set high standards for the clinical evidence that guides our decision-making, without sacrificing the clinician's expertise or the patient's values. By integrating evidence-based medicine in the care provided to patients with cancer and pregnancy, I believe that we can become more confident in which treatments we can and cannot offer these patients, and can get closer to predicting maternal and fetal outcomes with 20/20 vision.